Assalamu alaikum. During clinical consultation day. First scenario, Mr. Alexander, 30 years old, male, presented with diarrhea for 4 months. Vitals, blood pressure 110/70, heart rate 790, temperature 37.3. Take history and examine the patient, address his concerns. Here you go.
Right. Good evening. I'm Dr. Henry, one of the doctors here to see you. May I please confirm your name and age?
Yes, my name is Mr. Alexander. I am 30 years. 30 years, yes.
Wow, it's pleased to meet you. I'll be seeing you today and I'll be documenting some of your case. I was told that you have been having this loose stool for the past 4 months. Is that so?
Yes, that's right.
Oh, so sorry to hear about that. But not to worry. See how I can do to help you out. Is that okay?
Sure.
All right. Can you tell me more about this, your loose stool, how it started?
Actually, it started around 4 months ago, and since then, it is bothering me.
Okay. Was it sudden or it has been getting worse as the
It started
day goes by?
gradually.
Okay. Do you notice that is it just how does the loose stool you complain, does this stain with blood?
Yes, in last week, yes, it's contained blood.
Okay, so sorry. Then is there any like food particles, undigested particle on the food, on the blood? Sorry, on the stool.
I'm not sure.
Okay, and does it have an offensive smell?
No.
Does it have any? Does it have? Do you find it difficult to flush it?
No.
Okay, and then do you sometimes have some feeling of constipation? In between the loose stool?
No.
Okay. Sorry if I may ask, do you have any tummy ache?
Yes, with this loose motion, yes, I have some attacks with tummy pain.
Okay, so sorry. Then do you have any? Do you sometimes feel as if you throw up?
Repeat,
as in
please.
vomit, like vomit? Do you vomit and do you throw up?
No throwing up.
Okay. Or feeling sick, like
No.
feel sick? Okay. Any tummy swelling?
No.
Okay. Do you know of anything that you do that make the diarrhea get worse?
Repeat, please.
Do you know of anything that you do that make the diarrhea get worse?
Yes, it's since it started, it's getting worse. Yes, especially in the last week.
Okay. Does the diarrhea wake you up maybe in your sleep? Do you sometimes have that feeling of diarrhea when you are sleeping too? Have any episode during sleep?
Yes, it awakes from sleep. Yes.
From sleep. Okay. All right. So sorry. And do you know of anything that you do that makes the diarrhea goes away or relieves the diarrhea?
No.
Okay. If I may ask, do you have any condition you have been managing before now?
No.
No condition at all, like diabetes or high blood pressure, any previous? Okay. Any
No.
recent hospitalization?
No.
Any previous surgery?
No.
Okay. Do you have any fever?
Yes, I have.
Okay.
Sometimes I have fever. It's around 37 to 38.
Okay. So sorry. For how long now?
6 months.
6 months. Okay. Does it get better with any medication?
Actually, I take for some paracetamol, and it's improved. It's on and off.
Okay. Okay. So sorry. Any weight loss?
Yes. I feel that my clothes is getting looser.
Okay. So sorry. For how long now?
Around 2 months.
Okay. Does it change with do you have any change in the appetite? Do you have any reduced appetite?
Yes. My
Okay,
appetite is decreased.
Okay. Do you any recent travel?
Yes, I was recently in Africa around 1 year ago.
Okay. Do you have any contact with anybody that cough?
I'm not sure.
Okay, what was your mission in Africa? What kind of things do you do there?
I was just traveling for fun.
Okay, for fun. Okay, sorry, this is a little bit personal question. In the course of your travel, do you have any, like unprotected sexual intercourse, if you don't mind?
Actually, yes, this happened.
Okay, you have it. Okay, so okay. And do you have any? Have you been? Sorry, if this is a more. Have you done any test of HIV? Within the past,
No,
1 year. Okay. All right. Sorry. Also, yeah, if I may ask, sorry, do you have any headache,
no,
any neck pain,
no,
any loss of consciousness,
no.
any problem with your vision?
I'm not sure. No.
Okay. Any mouth sores?
No.
No mouth sores. Okay. What of
No.
any problem? Any neck swelling?
Actually, I have this. I think something under my and something in neck. I think it's a lump.
Lump. Okay. Where in your neck? If I can I see it?
No picture. It's
Okay. Do you have it? Okay. How many parts? Is it the lump? Is it just one place or is multiple? Is it multiple lump?
I think it's multiple. Yes, not only one.
Okay. Okay. What's of in your like? Okay. Any other parts of your body have these lumps and bumps?
I'm not sure.
Okay. Do you have any? Do you sometimes feel as if you cough? Any cough?
Not sure. No.
Any shortness of breath?
Yes, during this when I have this high blood temperature, I feel shortness of breath.
Okay. For how long now?
I think since the fever started, during the attack of fever, I had the rhythm of my heart and shortness of breath.
Oh, okay. So sorry about that. Does it get the shortness of breath? Does it get worse when you walk, or it doesn't? Even when
Yes,
you are at rest, it gets worse.
yes.
Okay. When you are sleeping, do you have to use more than two pillows to sleep?
No.
Okay. Any leg swelling?
Leg swelling? No.
Okay. Any facial swelling?
No.
Okay. I say you don't have cough, right?
Yes.
And any raising of the heart?
No cough. No cough.
Any raising of the heart?
Any?
Any joint pain?
No, no.
Any skin rashes?
Skin rashes? No.
No skin rashes. Okay. Do you have any tingling sensation or pain and sensation in your body?
No.
Okay. Sorry if I may ask also, what of your water works? How is it like? How's your water work?
Fine.
Fine. Okay. How does it affect your what sort of job do you do?
I am a student.
Student, how does it affect your job, your condition?
Actually, currently I'm unable to go anywhere because of I'm almost all the time needs the bathroom.
Okay. All right. What are you? Sorry, are you married? Let me ask.
I have a girlfriend.
You have many. Okay. How many? So sorry, this more. How many girlfriend do you have?
One.
Oh, okay. Do you use do you smoke?
Yes, 10 cigarettes.
Okay. So if you don't mind, you may need to stop the cigarette smoking. How about that? Do you consume?
I will think.
Okay. Do you consume alcohol?
Around 14 units. Yes.
Okay. Also, you may need to stop that too and cut down your alcohol intake. If you don't mind, sorry. Do you have any let's say do you mind if I examine you?
Sure.
Pardon?
Sure, you can start. Yes.
Okay. All right. I want to first of all do a general examination on you by looking at your eyes. Look at any pallor.
Patient is pale, underweight.
Any pallor.
Pale, yes.
Any gets pale. Okay. Any jaundice.
No.
Okay, then go to the neck and check, examine the lymph nodes. How the lymph nodes like any cervical and the axillary lymph nodes, all the lymph nodes,
There is a cervical lymph node. Yes.
cervical lymph nodes. Okay, and then examine the axillary. Then look at the the hands, check for any finger clubbing.
No finger
No,
club.
okay. Then look at the tummy, any scars, no scars. Okay,
No
then
scars.
then check do the abdominal examination. Check for the spleen. How is the spleen? Any splenomegaly, any liver, any hepatomegaly?
No, normal abdomen.
No, the abdomen is normal. Okay, then look at the chest and check anything in the chest, anything in
Normal
the chest,
examination. Normal.
the chest, normal examination. Okay, then from there I want to proceed. Then since the chest is normal, I want to look at the mouth. So can I see your mouth? Sorry, check for any oral, any cash, any thrush.
Any in the mouth, you mean?
Yes, in the mouth, any thrush.
Yes, there is a white layer of the tongue.
Okay. Do you have any difficulty in swallowing? If you don't mind.
Yes. I have been full during swallowing.
Oh, so
And I
sorry
have
about
been.
that. Oh, okay. And what of sorry to say also, okay, so sorry about that. Also I want to just can you do pronator drift and not check any weakness, pronator drift?
No weakness.
Okay. Okay. And I know all this examination I did will take a little bit of time. So I want to ask, do you have any concern?
Before the concern, since you look the eye for Bale Jones, the eye is red. I'm concerned what I have.
That's a good question, if you don't mind. Looking at your complaint, what is complained to me, and looking at you went to Africa and you had multiple unprotected sex, and looking at what I saw in your mouth and examination, I think you're having what I think maybe due to what we call your HIV. That one of the things I'm thinking. But we need to do some. I don't want to scare you. We need to do some tests to confirm it, and then which can also after that also have other things in mind. Also, if it could also be due to you're having a condition called abdominal, or disseminated TB, which can also cause the same loose stool you're having, and also looking at it could also be due to what's maybe an inflammatory bowel disease, a condition. So these are the things I'm thinking. But first of all, we need to admit we'll do some tests for you, HIV tests, also do some other tests, the rule out other viruses, and then we'll do look at the if it's positive, we need to enroll you and then start the treatment, because according to the guideline, if it's positive, we need to start the treatment, and we hope that you respond to it. At this point, we may not need to, because of the shortness of breath we're having. We also need to do some other tests like ECG, to then chest X-ray too, to look at your heart and your chest and see if there's any other condition that is seen in this condition, which may include some other opportunistic lung infection to rule them out. But any other concern?
Yeah.
Two
No
minutes
other
left.
concern.
Pardon?
No other concerns.
Okay. Okay. Thank you very much. Like I said, so after we do the test for you, we may need to also stop. We need to, like I said, cut down your alcohol consumption, and then we are meant to refer you to the smoking cessation clinic. And if you don't mind to, if test is positive, we need to also test your, if you don't mind, with your consent, test your partner, and then proceed. How about that?
Fine.
Okay, thank you very much. Well, at this, I will give you, I'll send you for a test to the lab. You do the test, and when the result comes out, we'll discuss more about that. Is that okay?
Sure. The other concern, do I need admission?
Then, like I said, as it is now, because of your loose stool you're having, and because of it has affected many of your system. You're having a difficulty in swallowing. We need to keep you and then start you on some medication for which we think is more likely keeping with candidiasis. Start you on some antifungi. Then we hydrate you because of you, since you're having shortness of breath, maybe due to you're having anemia. I don't know, but if depending on the results, we need to put on observation first of all, and then test, and then commence treatment. But we need to keep you on observation first, then proceed. then invite other health team to like the infectious disease doctors and other doctors that will be in charge of you. Is that okay?
Sure.
All right. Thank you very much.
Okay.
Thank you.
Examiner question, Dr. Aya, you can start.
So what was your case about?
I presented this 30 years old man who presented an account of 4 months history of loose stool, which was said to be accompanied by blood stain. However, there's also issue of abdominal pain and with oral mouth oral thrush with odonophagia and on weight loss with recent multiple sexual intercourse, unprotected sexual intercourse, and recent and history of travel to an endemic environment like place of Africa, and also there's low grade fever. On examination, general appearance is look wasted. There's obvious is having there's obvious pallor and there's oral thrush, which alongside there's generalized lymphadenopathy. However, the chest and abdominal examination is showing normal. Looking at my history and examination, I'm most likely patient tends to be having which acquired human advanced HIV, most likely stage.
Okay, so your first differential is HIV. What is next?
HIV, yes. Yeah, the next one could be also I'm looking at disseminated tuberculosis, TB, disseminated TB.
Okay. What else?
Then I'm also looking at inflammatory bowel disease as my other differential diagnosis in this case. Then, yeah, basically.
Did you ask about the family history?
No, I didn't. I didn't. That was it.
Okay.
I didn't.
Fine. So, how would you like to manage this case?
The management of this patient, we first of all involve after investigating. I want to start by investigating my patient by doing full blood count differential retroviral screening, hepatitis B, hepatitis C, hepatitis and then inflammatory markers. Then I want to do these two analysis, two microscopic and culture. Then I want to do the colonoscopy. For my patient, fecal protecting, and then I'll go proceed by doing the oral what do you call it upper GI endoscopy to also to rule out other non opportunity infection other than candidiasis as cause of the dysphagia. Then also we may need to, since he has outside that, I want to do chest X-ray, ECG, and abdominal ultrasound scan to rule out other subtype or subtool splenomegaly. And at the same time, I want to do a since there's multiple lymph node, to do lymph node biopsy. Then my part of the management involve multidisciplinary team involving the infectious disease unit, the hematologist, and also the counsel the patient on smoking cessation and alcohol consumption. At the same time, we want to commence if the result comes out to be positive, we want to commence antiretroviral treatment immediately. But however, if there's evidence of TB, we need to start the TB first, the TB treatment first before commencing the HIV therapy. But if the TB is negative, we need to start the HIV tablet immediately. After counseling, commence the HIV medication. At the same time, giving fluid because of since he's having loose strands and is kind of dehydrated, we start the intravenous fluid, admit for observation and give intravenous fluid. And obviously, and basically, they're given fungi like IV fluconazole for the odonophagia, for the esophageal candidiasis. And then if there's want to do the chest, if the bronchoalveolar lavage shows evidence of pneumocytic
I have just
prevention.
one question before the time finish.
Okay.
Why do you think this patient is having 1 week of bloody diarrhea?
Yeah, 1 week of bloody diarrhea could be due to other opportunistic infections. That is seen in HIV, may be due to the what do you call this? I'm forgetting the name of this condition. It's also seen in HIV that can result to the bloody diarrhea. The diarrhea is usually for 4 months. It's a chronic diarrhea, so the bloody is more like is a new,
new symptom. Yes,
new
it's
symptoms.
okay, fine. It is. Can I see now or not?
Yeah, go ahead.
I think 5 minutes by
Yeah, 5
cycle.
minutes. Okay. I will ask him clear differential, Dr. Henry. Give me 3 clear differential diagnoses.
Yeah, in this case, I will, like I said, first of all, is advanced acquired immune deficiency syndrome, which is advanced HIV. AIDS, that's number 1. Number 2, I want to go
So
with,
infectious. Okay, infectious diarrhea. What else?
infectious diarrhea. 2, because of the it could be due to like I mentioned, inflammatory bowel disease.
Okay, inflammatory bowel. Second.
Yes.
The third.
Yes. Then third, like I mentioned, third could be due to
You have to
TB.
say it.
TB.
Okay, TB infectious still. Tell me another more linked to the diarrhea here in this scenario. Weight loss, loss of appetite, bloody diarrhea. You didn't ask about family history. Yeah, you didn't ask about family history, but it could be positive. So you have to rule out what?
If a positive issue of family, then in this case, I want to rule out
the family
diarrhea.
history is his uncle had colon cancer at 40.
Yeah,
this is my question.
So, malignancy.
This is why the patient is 30 years. You have to start searching for colonoscopy 10 years ago before the family history.
Perfect, Doctor. You said it. So clearly, this is the third differential. You have to rule it out, and it could be one of the concern. Okay, well done, Dr. Henry. Thank you, Dr. You can start the comment, then I will comment.
Actually, it's not much, but he reached. He did just half of the differential, not all of them, because there is one differential or 2 differential already missed. This is a case somehow it's also it is HIV, but there is other differential. So from started, me preferably I don't like good evening or good morning. It's best to try hello, whatever the time you will have the exam. Just hello is enough. The other thing for the in the beginning you consumed around 40 seconds just in the introduction. Maybe you can just make it simple. Hello, I am doctor, whatever, and we are here to examine and discuss. And all of this, maybe around 20 seconds is enough for the introduction. The other thing, during asking the question, you have to leave a space for, when you ask them for onset course duration and the specific, you will just say, is it something gradual? Is it on and off? Increasing, decreasing, or the same? Just like this, small questions. Also from the beginning, no need to say, tell me more about your music. Just tell me more about your complaint. Do you have any other complaint? Maybe he will tell you another complaint. Then when you ask him to tell you more complaints, you may find the answer in the other complaint, not the beginning of the complaint. As usually, most cases have more than one complaint. But of course, sometimes they will not tell you another complaint unless you ask it. But just try your luck sometimes. The other thing is when I told you that I am a student and it impacted me. You didn't tell me you have to. Can give you sick leave or anything to help me with that, or at least referred me to social worker. No, since he's a student, at least give him sick leaves to try to help him regarding this impact in life. What else? Yes, regarding the weight loss, you asked me. I told you it's feel loser. I'm not sure that you asked about over how long or not, because here I wrote that since you didn't ask about the duration. The question of the weight is how much over how long. What about your appetite, intended or not? You didn't ask intended or not. Also, the other thing is the cigarette. When I told you that I drink cigarette, you have to say smoking is bad for your condition, especially smoking is bad, especially in your condition. If you allow me, I can refer you to smoking cessation clinic. What do you think about that? But you told me you have to stop smoking is bad. You have to stop. I think you was a little bit like very strict. The second thing, why cut down alcohol? I think 14 is within limit. This is regarding the first thing. So this case was about a young male who has two things. He has both medical history of 6 months of loose motion, weight loss, and high body temperature or fever. Then currently in the last week, he is having bloody diarrhea with red eye. So we have two events. So the family history is positive. His uncle had this cancer when he was 40. And he had casual unprotected sexual relationship. Other than this, the examination was only generalized lipidopathy. Since the case is having bloody diarrhea, you have to examine. You did the examination well. The only thing is the digital rectal examination. Any bloody diarrhea, the digital rectal examination must be done, or any case you may suspect it could be cancer. You should colon cancer. You must do digital rectal examination. Just offer. It is like a bonus, since they will not say, okay, you can do. So this was a case, the provisional diagnosis, chronic diarrhea, weight loss, fever, and generalized nephropathy, and oral candidiasis, and positive sexual behavior, and also travel history. The first thing is HIV with opportunistic infection. Most likely it is cytomegalovirus, but cryptosporidis also needs to be ruled out. Other differential, inflammatory bowel disease, colon cancer, and lymphoma. At the end, I know that's a lot of differential, but whenever you say HIV, you have to say also lymphoma and TB. All of them has similar symptoms, but in the TB, you will say, but again, is this, I couldn't find any cough or any chest symptom, but this must be ruled out. So what else? So the investigation you told well. You have to, other than the basic investigation, you have to do HIV tests with 3 tests. HIV antibodies, which is also called B24, viral load, and CD4. TB test, also three investigation. Quantiferon, three sample of morning acid fat bacilli for also culture, and the other thing is chest X-ray. Of course, stool studies and imaging and colonoscopy. Lymph node biopsy. The other thing in the examination you must is checking the status of the fluid of the patient. I mean, you can ask standing blood pressure and make sure that he doesn't have dry mucous membrane or decreased skin turgor. This must be done for any patient that's having any loss. The other thing in non-pharmacological, you must say partner tracing and screening. Then the pharmacological is the same according to case. If it is HIV, it is active antiviral therapy. If it's just enough to say according to case. That's all that I have.
Thank you. Thank you.
Okay, thank you, Dr. Aya. Good presentation. And I think Dr. Henry did good in the clinical judgment in the investigation. He mentioned even the stool analysis, stool culture, which is very important.
Even for inflammatory bowel disease, she will do colonoscopy and she will reach the cancer.
Yeah, and he said also a fecal calprotectin. He mentioned the lymph node biopsy, which is also good. As a clinical judgment, I think he can get a good mark. The examination as well, but the examination always, as Dr. Aya said, diarrhea patient, you have to examine for the posture, hypotension, dehydration signs. Not only that, you can even ask the patient. Yes. Yes, Dr. Aish.
Yes, I'm saying also the digital rectal examination, diarrhea, fluid status, and abdomen and digital rectal examination.
Yes, so he can get borderline in the physical examination. The posture hypotension, as well as the lymph node examination he did, but the dryness, either the skin trigger or the mucous membrane, the dehydration or dryness.
Mm.
And the history also he has to ask about how you are compensating for this loose motion, the frequency as well, to give a clue or to give idea about the severity of the diarrhea. Okay.
Yeah.
One
Thank you.
more. I wrote it in the chat box. The magic question of diarrhea.
Yes, regarding this, also it must be more at the beginning.
Yes, in the beginning. Yes.
Relation to food, is it flushable, contain blood? Also, sometimes you can ask, is it related to, did you had any antibiotic in the last month? But currently, the Clostridium difficile doesn't come anymore.
Yeah, Clostridium difficile. Okay, these are the four questions. So you have to ask at in any scenario of diarrhea. First question: does it awake you from sleep? To rule out irritable bowel syndrome. If yes, the patient awakened from sleep, so this is not irritable bowel syndrome. However, in the severity of severe form of irritable bowel syndrome, it might awake the patient from sleep. The second question, is it related to the food? Here you can say the pizza, pasta, and beer to rule out celiac. And the next question also will be related. Is it flushable or no? To confirm this is malabsorption diarrhea or no. And the last question contains blood to rule out the cancer or other infectious disease like HIV in our case. The constitutional was positive here. Dr. Henry already know it, and he picked up them. So I think the history went good apart from the HIV risk habit. You didn't conclude why this patient he must or he might have HIV. Yes, family travel history, but it was 1 year ago. You ask about how many girlfriend. Why you don't ask about is it do you have any casual relationships?
No,
And if
he
he has,
asked.
he asked about how
Ask
many
only
girlfriends.
only about no. He asked also around the casual relationship, but he didn't ask about the tattooing and piercing and the others.
Exactly.
Only
Yes.
one.
Blood transfusion. Yes. Blood
Mm.
transfusion, piercing, tattooing, and
Mm.
the blood transfusion. All this question will give you the clue if this patient is having HIV from which risk habit he had. Okay. But it's clear here it was a casual relationships. You can also ask, is it protected or no, or was it protected or no? He will say yes, it wasn't. So you can conclude mostly this is HIV. Family history is very important, either to rule out or to rule in the cancer. If there is family history of cancer at any age, and any other, not only that. So if he has family history, how old this patient is having this cancer, any family member is having the same cancer or any cancer, to rule out or to use the what's called Amsterdam criteria. Okay. Then the examination we already mentioned, the dehydration. Yes, I wrote also in the chat box about the complication, serious complication associated with the complaint. You have to ask about dizziness. You ask about something else which is not related to the case. I think you ask about something else. It's not the dizziness. Okay, the dizziness here is very important. Why you ask about the dizziness means the patient is severely dehydrated, or you can ask about the yellowish of the eyes for jaundice. I mean, and at this time you can also consider, for example, ulcerative colitis associated with PSC. Uh,
Mm.
you got it?
Yes, yes.
Yeah. So
Thank you.
I meant cholangiocarcinoma or even uh, primary sclerosing cholangitis. Okay. By this way, you can show the examiner that you are ruling out the complication, the association, and the severity of diarrhea in the history. Not only the history, even the examination. As I said, the posture hypotension, dryness, as Dr. Aya mentioned also. These are the things. I think we are covered this topic. We go to the next scenario. Dr. Aya, your patient, 30 years old, John Smith, presenting with short of breath for 3 months.
30 year,
Yeah, John Smith,
short.
a male. A male, short of breath for 3 months.
Okay, I will just take 2 minutes and come back.
No worry. We will ask others for any comment, any question from others, any comment. Anyone want to add any comment? It's a good case and it's classical case of PACEs. HIV, cancer, inflammatory bowel disease, or it can be malabsorptive diarrhea, celiac, pancreatitis, or complication of Crohn's, like short bowel. So you have to conclude what diarrhea you are dealing with. Is it malabsorptive? Is it watery? Is it infectious? Is it bloody? And from these questions, you will know which diarrhea you are dealing with. If you have positive constitutional symptoms, you have severe form of diarrhea, either cancer, HIV, TB. Okay. Lymphoma as well, you can put it as a cancer or associated cancer with diarrhea. Anyone has a question, please raise it. Write this question I wrote in the chat box. It's very important for question. At least you will narrow your differential to 3 or a major type of diarrhea. Okay, but if you will not ask this question, you will lose the case. As I said, is it malabsorption? You have the question of malabsorption. Is it watery? You will have the question, is it flushable or no? Is it bloody? You have the question of blood. Is it infectious? You will have the history of constitutional or travel history. Okay, so it's these questions will help you and will guide you to which type of diarrhea you have or the patient is having. Plus, as I said, the severity or the serious association of dizziness and jaundice. Waiting for Dr. Aya. If you're ready, Dr. Aya, let's start.
Okay, I can start.
Okay, here you go.
Hello, this is Dr. Salah. I'm one of the doctors here in the clinic. May I confirm that I'm talking to Mr. John?
Yes, doctor.
We are here to discuss your condition, examine you, and address your concern. Is that okay with you?
Yes, doctor.
Okay, can you tell me more about your complaint?
And doctor, for the past 3 months now, we're having this shortness of breath, doctor. I don't know. It's getting worse, doctor.
I'm sorry for that. And as I understand, it is since 3 months.
Yes. Yes, doctor.
Is it on and off or all the time?
Doctor, it's all the time, but usually worse whenever I walk, and do some exercise. Yes, doctor.
It increased with walking. Okay,
Yes.
and is it since it started? Is it decreasing, increasing, or the same?
Initially, it was not as hard as this. Initially, it was just whenever I walk for a very long time. But now, even when I walk outside, I do feel it, doctor.
Okay, I'm sorry for that. We'll try to solve this out. Okay, so
Okay, doctor.
can I ask, did you before these 3 months you was completely normal?
Yes, I've been good. Doctor. I've been good.
Any similar attack?
No, not at all, doctor.
Did you notice any variation between morning and night for this shortness of breath?
No, it's both morning and night, doctor. It occurs.
Okay. Did you notice anything make it better, like resting?
Well, when I rest a little bit, I feel better. Yeah.
Okay. Did you notice anything make it worse other than the exertion, like exposure to dust, to stress, or anything?
Not at all, doctor.
Okay. Do you have any racing of the heartbeat?
Occasionally, I do have it, but not all the time, doctor.
Okay. Can you tell me more about this?
And sometimes I just feel as if, my heart is beating very fast. Sometimes it beats, I don't know. Yeah.
Fine. Any cough?
Cough. No, not at all, doctor.
Okay. Did you had any lower limb swelling?
What's lower limb, doctor?
Uh,
You mean
uh,
my legs?
yes,
You
lower
mean
leg
my leg?
swelling. Yes, yes, leg
Okay.
swelling.
Legs. Okay. Yeah. No, not. I've not noticed it, doctor. I haven't.
Okay. Do you have any chest pain?
Chest pain? No, doctor.
Any does you awake from sleep searching for air?
No, doctor.
Are you able to lie flat?
I can lie flat, but sometimes when I lie flat, it becomes, I feel more shortness of breath when I lie flat, doctor.
So you mean can I ask how many pillows do you sleep on?
I prefer to lie down in my couch,
Okay.
not.
So are you able to lie flat or not? Does your symptom
Mm,
increase by lie flat?
yeah, it increases when I lie flat, doctor. Yes, doctor, it does.
Oh, okay.
So I prefer sitting
Fine.
down.
Okay. Can other than this, do you have any nasal stiffness or bleeding?
Any what? No,
Nasal
bleeding.
stiffness.
No.
Okay. Do you have any high body temperature?
High body temperature? No, doctor.
Any weight changes?
No, doctor.
Any change in your appetite?
Appetite? No, doctor.
Any becoming more pale?
No, doctor.
Okay. Do you feel more fatigued?
Yes, I sometimes feel very tired, doctor. Yeah.
Can you tell me more about this fatigue?
And not all the time, I just feel as if I'm weak. I don't do my normal activities the way I used to do it, previously.
You mean this fatigue is only for 1 week?
No, I don't usually feel, I usually feel tired going to work these days. I'm usually tired all the time, feel so
Uh,
weak. Yeah.
okay, so you mean okay, so this fatigue is since the symptoms started?
No, just I think for the past 1 month now we're having this weakness, this fatigue, tiredness, kind of.
Okay, so did you notice any variation between morning and night?
No, doctor. No.
Anything make it better or worse?
When I sit down, when I sit down, I get it relieves me a little bit compared to when I walk.
Okay, so other than this fatigue, do you have any neck swelling?
No next
Weather
week.
preference?
No, doctor.
Lump or bump anywhere?
No, doctor.
Any night sweats?
Nice sweat. No, doctor.
Any skin rash?
Skin rash. No, doctor.
Do you have any joint pain?
Joint pain. Not really. Just but no joint pain. No.
No, any back pain?
Back pain. Yeah, I have back pain. That's been there for a very long time.
Yes. Can you tell me more about this back pain?
I started having back pain for the past 4 years now, doctor. Yeah.
I'm sorry for that. Can you tell me the sites?
Yeah, just at my back. I just sometimes feel, pain at my back.
Okay.
My upper
Is
back.
it
Yeah.
only pain only or there is a stiffness?
No, just pain, no stiffness. I don't think there's any stiffness.
Okay.
I just feel back pain. Yeah.
Okay. Is it more with movement or rest?
No, both movement and stress. But these days I learn to live with it. Normally.
Okay. So you mean it's more with movement or
The back pain is there. Is there. Is there.
all the
It's
time
there
with movement
all
and
the time.
rest?
Yes.
Okay. From 0 to 10, how 0 minimum and 10 is maximum? How you would like
I'll
to
give,
grade it?
I'll give it a 4.
Okay. Okay. And did you notice any variation between morning and night?
Morning and night. No.
Is it on and off or all the time?
It's just there. It's just all the time. It's not very serious, but it's just there.
Okay, fine. So can I ask you, other than this, do you have any past medical history I should be aware of?
Not at all. I don't. I just no. I don't.
Okay. So there is no medication list and any surgery or a hospital admission?
Yes, I've had one hospital admission. That was 2 years ago, doctor. Yeah.
For what?
I had a chest pain, and then with difficulty in breathing, I was admitted, and then I
And
was given
what
some
was your
ox.
diagnosis?
They didn't really tell me, but they just felt that I was given some oxygen, and then I got better, and then they discharged me. That was when I went to. I had that when I traveled to Africa. There was no much health center there, so they just give me some medication, oxygen, and then they discharged me with some medication. I get better eventually.
Okay. Okay. So, can you tell me more about this travel history?
No, it was a long time ago. That was 2 years ago. I just they felt that they told me that it was part of my condition. What I do have is they say is seen in my kind of person, but they didn't tell me more about it because I was in a hurry to go back. I didn't really stay.
Okay. Okay. So I understand you didn't continue your investigation. Okay.
Yes, I just
Regarding the travel, where were you?
and that was when I went to a place called Togo, but yeah.
Can I
So it's
ask
a
which
French.
continent is this? Is it
It's
in
in Africa.
Africa
It's in
or
Africa. Yeah, it's a French-speaking
yes?
country. I just went there to see a friend, and I had shortness of breath, and they gave me
Uh,
some, and chest pain, and they gave me some oxygen, and
yes.
had a training, and then I was discharged, and I left.
Okay, I understand.
Mm.
So, okay, did you had any contact with a chesty person or someone who is coughing,
No, not at all.
or
Not at all.
anyone has tuberculosis?
No.
And you received your vaccination before you go and during it and after
Yes,
that?
yes, 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 yes,
Okay.
yes.
Okay. So, can I ask you, do you have any leg pain?
No leg pain. No leg pain.
Okay. And did you had recently any long trip?
Pardon?
Long trip.
No long trip. No.
Have you been, I mean, a long time for immobility?
Immobility. No.
Okay, fine. And other than this, do you have any change in your water work?
No. What else is okay? It's
Okay,
okay.
any family history of similar condition?
My dad has similar condition. Yes. But yeah, before he died, eventually, he died of heart condition, and bless him,
At what
yeah,
age? I'm sorry for that.
yeah.
At what age?
He died when I was a baby, when I was a child. I think should be around the age of 40 or thereabout. If I'm not mistaken.
Okay, and okay. So, did he had any special diagnosis?
I can't remember. I can't recall. But he said that it's
Okay,
once in the family that that most likely when I went to Togo, they said that it's what I had then was related to my family, but they didn't really tell me what I had because I was in a bit to leave, so I left.
okay.
Mm.
And can I ask you, did you had any blood clots before?
Blood clot? No.
Okay. So, do you smoke?
No. I don't. I don't.
Drink alcohol?
No.
What's your job?
I'm a teacher. I'm a teacher.
Okay, and it has this impacted your job?
Yes, just like I said, I'm usually tired of going to work, so I've applied for, week. I've taken all my annual leave just within a couple of 3 months. I've taken all my annual leave.
Okay,
Mm.
fine. I'm sorry for that. We will try to give you sick leave until we try to reach this out. Okay.
Oh, bless you.
Other
Thank you.
than
Thank
this,
you, doctor.
okay. Do you have does your intern to read when you leave it alone?
No,
Any mouth ulcers?
no,
Any genital ulcer?
no.
Okay. And do you have any blood disease that runs in your family?
I know what? Sorry.
Any blood disease runs in your family?
No. No lung disease. No,
Any itchiness after you bath?
no, doctor.
Okay. Do you have any yellow discoloration in your skin?
No, doctor.
Difficulty of swallowing?
No, doctor.
Any change in your bowel habits,
No,
like loose
doctor.
motion or hard motion? Okay.
No.
Fine. Any headache?
No, doctor.
Any weakness anywhere? I mean, limb, arm or leg weakness?
No, doctor.
Okay. Any vision problem?
Any what?
Vision. Any problem in your vision?
Yes. I've not been seeing very well these days for the past 1 year now, but I think it's just normal.
Can you tell me more about that?
Yes, usually I've not been seeing very well. So I went to see a doctor. He said that I'm short-sighted. So they gave me glasses. So, but they said that most likely, yeah, I'm using glasses for that.
Okay. So do you have any, I mean, are you able to see the sides of the road?
Size of the what? Now with my glasses, with my glasses, I can see a little bit, but not as I used to see previously.
Any problem with night vision?
No, not at all.
Okay, I will start the examination. Just taking the general look.
Dr. Bazim, I've sent you the image. Dr. Bazim, I've sent it to your WhatsApp.
Okay, I will do.
Okay, 2 minutes left, but I will add 2 minutes for the.
Okay, so I will just take. Other than the general examination, I will make sure that there is no clubbing of the hand, no torrid stain. I will just.
So tell me what you want to examine. Just mention what you want to examine. I'll tell you.
I will just start examination of general look and hand.
On the hand, yes, the hand. The hand is looking like a spider. The hands.
Okay. So yes, I will check with him.
The photo and the chat looks.
Yes, I saw the photo. I will start examination by the hand is spade like. I will do the
it's not spade like a spade. It's like a long, very long.
Yes, I will do the examination for Marfan, the one that I will let him check the one that for the hand. I will let him put the thumb between his fingers and check if it appears in the other side, and also put the thumb around the wrist.
Okay,
and do the collapsing pulse.
Okay.
And then I will check.
Positive.
Okay, and I will check for the mouth high arched palate, the TVB. I will just listen to the chest, check the expansion, and if there is any basal crepitation, only basal percussion basal, and I will check the chest, and also listening careful for aortic regurgitation. I will let the patient go in the front, leaning forward, and check the third area, the left parasthenial area for the aortic regurgitation. Most likely, even if there is diastolic memory, I will not hear. But if there is, since there is collapsing pulse, so most likely he has it. So other than this, I will just for lower limb swelling, and I will check the span of the hand to the body. Usually, he will have longer lifespan. Longer, I mean hand span. So, what's your concern?
Doctor, what do I have, doctor?
Okay, I appreciate your concern. I'm concerned that you have a family condition called Marfan, or this condition is usually runs through the family. Do you have any before this? Do you have any high blood pressure?
No, not at all, doctor.
Okay. Okay, and you told no. Okay, so most likely you have a condition called Marfan. This is a condition that runs in the family. So it can lead to the symptoms like you had, like this shortness of breath and the back problem. So what I would like to do now, I will run urgent tests, and I will do for you some investigation. If anything came abnormal, we may consider admission. Otherwise, we will sit back again and discuss your results.
Okay, thank you, doctor.
Okay, examiner question.
Okay, then thank you very much. Then can you present your positive examination findings and the likely differential diagnosis?
Okay, this is a young gentleman with positive family history of cardiac death at 40. Other than this, he has chronic shortness of breath with shortness of breath, and he's unable to lie flat. On examination, he had a morphinoid feature in the form of increase the hand span in proportionate to his body, and some morphonate features, and also aortic regurgitation. So my top differential for this case is this shortness of breath. It could be related to valvular abnormality that might come at Marfan, like aortic regurgitation, or other abnormality like microregurgitation. Other differential for this shortness of breath, I need to rule out pneumothorax. But against this, the chronic onset of this shortness of breath, other causes of shortness of breath like anemia and should also be ruled out.
Okay, I will investigate this patient.
I will investigate this patient. So I will start with the basic investigation, CBC to make sure there is no anemia, RFT, LFT, and urine analysis. Other than this, I will do test X-ray, ECG, and X-ray, and X-ray is if we still cause of not confirmed, we can do also a CT, and also of course an echo. Other than this, I will do a genetic test for either he is having Marfan alone or other causes. I mean, like other symptoms that also may be similar to Marfan. Other than this, so then I think that's all.
Okay, how will you manage this patient?
I will put him on after the investigation. If the CBC, if there's the investigation show something that's alarming, like I mean, the chest like a pneumothorax or CBC show very low, or I don't think CBC will show anything, but anyhow, this ECG or echo showed something alarming, I will consider admission. But other for the management, I will also do genetic counseling for genetic referral, and multidisciplinary team include the chest doctor, the lung doctor. I mean the cardiologist and pulmonologist. The pharmacological treatment according to the code, if it is related to valvular abnormality, the treatment will be if he is symptomatic or not. If asymptomatic, it's just medication like diuretic, or according if the case. I mean, just for the cause. If it is or surgery, he may need surgery. The end.
Okay. Okay. If it's not
Of course,
Marfan
also
syndrome.
ophthalmology also.
Okay, good. Assuming this patient does not have Marfan syndrome, what should that thing like can explain similar feature that you see in this patient? If not Marfan.
There is the other patient that may show feature like Marfan,
other condition that can explain that
there
outside
is
the Marfan.
like Klinefelter syndrome, which will have infertility. I forgot to ask about this. Other is homocystinuria, will have I mean the eye will show the eye lens will be downward. Other in the Marfan it will be upward. Other than this, as a part of twin 2B, but against this I couldn't find any features of phochromocytoma.
Okay, thank you very much.
And also it could be as family are a little bit low, or something like gingivitis, but this is usually in children.
Okay, thank you.
Okay, give me Dr. Finish, Dr. Henry.
Yes, I'm done.
Okay, I need 3 clear differential, Dr. Aya.
I think it's so. This shortness of breath. Since it's only the only symptom that he had is only shortness of breath with some back pain, which could be due to laxity or fatigue. My top differential for this case is will be valvular abnormality, most likely aortic regurgitation. Other than this pneumothorax, but as I told again, this is chronic, not acute. Other, I would, since he has short breath and fatigue, anemia should be ruled out.
Perfect. Yes. What about deformity in the back? Can it
Yes, also
affect?
kyphosis. Kyphosis can lead to restrictive lung disease.
Okay. Okay. Thank you, Dr. Aya. Dr. Hilary, you can comment.
And thank you very much. That was a good one. You did well. Your flow was okay. You asked a lot of questions. Just that you spent much time in the history. You spent 11 minutes for history, which is to me is far. The use is
Yes,
too much for just the history.
uh,
I don't
because I couldn't
know.
find anything, but I must have seen the patient's area.
Yeah, as we have some systemic review, go from head to toe, systemic review, at least you should have gotten some things for the eye. You ask them very late after when you've seen the pictures. Sometimes the patient may be wearing some clothes, you may not see, and many times you may be wearing glasses, even you may not be able to see the so-called upward displacement, or you may not even see it. They may not come with short-sightedness, basically. So when you can't even see it with ordinary eye. You may except when you looked at teach using your what they call it slit lamp. So sorry, your what do you call this stuff? I'm forgetting the name of this. So although for the history, like I said, you should have your systemic review was not so detailed. That was one other thing. Although you tried, you did some other thing which was good. Then for the examination, you did examination for atrial fibrillation. You didn't check. Patient say he's having some shortness of breath. He's having heart palpitation. He's having palpitation, heart racing, something. So you should have examined for atrial fibrillation. I don't. Did you do that? I don't think you did that anyway. Atrial fibrillation is a very. It can have to you also the same thing in this particular patient too. You checked at the mouth, which you did. Many times, patient with Marfan syndrome may not have, any cleft pellets. May have, like you said, eye arc, definitely, and then you check which is good. You look at the foot, may have some flat foot. Look at the hands like you did. You check for the arachnodactyly. You check other markers of aortic regurgitation, like dancing carotid, the Muset sign, all the signs. Can just do the important ones and then check. You only did collapsing pulse, which is good. Which patient you should have also make an attempt to do some other signs of the aortic regurgitation which this patient has. The patient has aortic regurgitation. You are right. You got the diagnosis right. He has aortic regurgitation likely to Marfan syndrome. Another thing that can explain that, in the absence of the eye problem, maybe due to the Ehlers-Danlos syndrome, which can also explain that, and also what they call Lewis-Diet syndrome. It came out in my exam, the Marfan differential diagnosis of Ehlers and then what they call Lewis-Diet syndrome, typically. So it's also can also have similar pattern with this, basically. And then they have similar pattern with this in the sense that although they don't have the what they call the ectopic lengthy that the Marfan syndromes have. That's one thing that tends to differentiate it from Marfan syndrome. However, then also the valves to not just the aortic valve, also look at the mitral valve like you did. Check for me. So many times they come down with mitral valve prolapse, and that is also some other key feature you may see in this patient. And basically, like you said, you did well, basically. Thank you. Then for the examination too, for part of the another question they made that they also asked me then that if this particular patient comes with chest pain in the emergency, what will you think of?
Okay. Are you done, Dr. Hilary?
Yeah, can you hear me?
Yeah,
Yes.
yeah, we hear you. Okay.
I was asking that. I was also asked that if this particular patient come with chest pain, they also asked me that if this particular patient come with chest pain, what are the likely things that come to my mind that is of cardiovascular importance? I said myocardial infarction. They said what else? They now corrected me that I should also think of aortic dissection. Basically, they may come down with aortic dissection by having this chest pain that is sharp, that radiates to the back, with definitely how will I manage it. So also part of the investigation we need to do in this patient outside an echo is an aortogram. You have to do what they call an aortogram, look at the aorta, and then be able to measure you can do it with an echo too, basically too. They also ask for an aortogram too, which is also important investigation what to do for these patients. I think that is that. Thank you very much.
Okay,
Thank
so you want to say the differential in this patient, myocardial infarction, and the top, of course, aortic regurg, so valvular heart disease. Then the mitral myocardial infarction, acute coronary syndrome.
In this patient, it's MI is unlikely in this patient. When I mean in this patient, the first diagnosis is aortic regurgitation, like she mentioned. Other
Okay.
like she mentioned, aortic what do you call it? Aortic regurgitation. Then other thing you want to think of in the person that have Marfan syndrome, in this case too, that have shortness of breath too. You want to think of mitral valve prolapse. In this case, that can also cause similar shortness of breath, but in this case, they may have some chest pain, which the patient does not really have in this case. Also, like the what she said, the bony abnormality.
So you mean that there is some red things that not be ruled out. You mean by this myocardial infarction, right?
No, yeah, they said.
You mean that even if there is no chest pain, any case of shortness of breath, you need to exclude acute coronary syndrome, as I understand.
No, MI is not a differential diagnosis here because MI is sudden. It is not. It's not a differential. I didn't mention MI. I mentioned aortic regurgitation. I mentioned mitral valve prolapse. I also mentioned the skeletal problem. Although in this case, like what they really asked me is if not Marfan syndrome, which other condition can explain that? His whole manifestation. In this case, you have to think of other or connective tissue disease such as the Ehlers-Danlos syndrome can have similar pattern too, especially they have certain variants of it. And also, they also mentioned what they call the Lewis-Dietz syndrome. Lewis-Dietz syndrome. I think it's pronounced, LDS is a Lewis-Dietz syndrome. Can have similar pattern too, with the same manifestation, aortic regurgitation, like this patient has typically. So the question can go in similar form. Also, the other question that they asked me another question, which is not in keep, which is that if this patient presents with chest pain, what will I think of? That is cardiovascular in origin, not they say of cardiovascular interest. And I mentioned some pneumothorax. I said no, that as you mentioned, that's related to cardiovascular. I mentioned MI. They say what else? Which unlikely because that may not be the answer. What they are trying to explain, but it could lead to aortic dissection because they have this aortic aneurysm, which can, result to dissection. Basically, it's a different question entirely, not what the patient presented with. Basically.
Okay, so they ask you for differential of short of breath, and they ask you about the
differential of chest pain.
Chest pain. Okay.
Chest pain. Yeah, that is of cardiovascular interest. Because I was mentioning pneumothorax. I said no, that is related to cardiovascular system, not so. I was not mention. I'm not mentioning myocardial infarction. That's what else.
Okay. So let's repeat
so what
them.
they told me.
Yeah, we will repeat them as a cardiovascular cause of chest pain in Marfan syndrome. In the top of them, aortic regurg, right?
Yeah.
Or yes, acute aortic regurg.
Aortic dissection. Yeah.
Aortic dissection is the second one. The third one will be as a chest pain and cardiovascular related.
Yeah.
So we mentioned the aortic valve, either aortic or mitral. By the way, mitral regurg also can cause chest pain.
Yeah, mitral valve collapse too can cause chest pain.
Yeah. Okay. And aortic dissection and pericarditis, right? Can it be?
Yes, pericarditis. Yeah.
Okay. These are the cause for chest pain and cardiovascular causes. What about chest pain related to the respiratory, Dr. Aya? You can mention them. In Marfan, particular.
I think pneumothorax, like
perfect,
as I said
yes.
before.
Pneumothorax, perfect. Second.
I'm not sure regarding pulmonary embolism, but I think
yes,
it
like
happens.
Pleurisy. Yeah, it can cause pulmonary embolism. What else?
Pleurisy? I think pleurisy, yes.
Yes, okay. And you can say
And also,
also,
I was searching also on aortic dissection, but again, this patient, I thought I because I didn't have enough time, I was want to say I would like to put this patient close monitoring since I found him on, because he may come also with aortic dissection.
aortic dissection will call it as a cardiovascular, not as a respiratory. You got my point?
Yes, right.
Okay, so aortic dissection, one of the cardiovascular cause of chest pain in Marfan. But respiratory wise, as you said, the first one, pneumothorax, the second one, pulmonary embolism, the third one, you can say pleurisy. Okay, I think these are
Okay.
the possible question for Marfan in both presentation. Let's go to the comment. My comment, I mean. Yeah, I think the case, you have to see the case earlier. You can ask him, can I see the patient or have a look to the patient?
Yes, I think since 7 minutes passed and I didn't reach anything,
Exactly.
maybe you can start asking about the patient.
Yes, can I see the patient or can I have a look? Why? By the spot diagnosis, you will know this is Marfan, and you will ask about the complication of Marfan in each condition, either chest or cardiovascular. But at least you conclude from the history that he has a history of orthopnea, right?
Yeah.
He had orthopnea, right? So it's valvular disease.
I also something I didn't know how I thought that if any patient has unable to lie flat, he will also have paroxysmal nocturnal dyspnea. But I
Yes,
was a
so
little
it's
bit
related to the
confused.
cardiac, short of breath
Yeah.
because of cardiac, and awake the patient from sleep as orthopnea, right? Or
Yeah.
yes, orthopnea or
Yes.
paroxysmal nocturnal dyspnea, paroxysmal nocturnal dyspnea, BND. So it's mainly
Yes.
cardiac. Here the case was short of breath, not related to the respiratory. It's mainly due to the cardiac issue. And from the awareness of heartbeat, you can know this is related to the valvular or there is palpitation. So you can conclude aortic or sorry, valvular heart disease. Okay. In general, as a systemic review, you ask the questions well. You talk longer, yes, in the questions, but again, because the case is not clear, when you conclude the case related to the cardiac, I think you can finish the case earlier. The examination steps also was good. You catch the finding of our aortic regurg in the form of collapsing pulse, and I don't think the arrhythmia was there. Dr. Henry is saying there is AF. I don't know if
No,
I
no, there was no AF, but you would have checked because of the palpitation. Patient
yeah,
does not have AF. Yeah, patient does not
but
have AF, but
if you put
uh,
your
But
hand
he
on the
must, I
pulse,
must have done all the
mm,
cardiovascular examination. But the thing is,
yeah,
the only thing that I usually don't get the AF from the pulse since there is no time, but you can get it through the
yeah,
heart
yeah.
easier.
Because I was asked in the exam. They asked me what was the pulse like. To be candid, when I checked that pulse, the patient had the pulse was even slower. So although in the feedback they didn't comment anything in the feedback because they also said the pulse was slower when I was
yeah.
examining the patient, but I just said the pulse was not. But they asked me what was the pulse like. They asked for them to have asked me what was the pulse. I felt that probably there's a catch in the pulse. I don't know, but I didn't feel that I didn't get anything in the pulse in
It's
the
okay.
feedback. Mm,
If you do a lot of
mm,
pulse examination, you will know this is either collapsing
mm.
and
Yeah,
a wide pulse pressure. You can know from
yeah,
the examination of the radial pulse
yeah.
and the bounding
That's yeah.
examination, bounding pulse
Mm,
for collapsibility. Okay, we can add also to the short of breath respiratory cause in Marfan, Dr. Aya said, the restrictive lung disease. So they might have any
yeah.
chest
Mm.
deformity that can cause this short of breath. Okay. The differential also was good by Dr. Aya. You want to add anything, Dr. Aya?
No, I think this all.
Okay. Dr. Henry, any other comment?
Yeah, like I said, you should just look the LDS, which is a very strong differential to Marfan syndrome. You can just go through it because that was
You can
LD,
share it because I don't know
yeah,
exactly
mm,
the term.
Lewis Dice syndrome, and then one of the variants of Ehlers-Danlos syndrome, one of the variants. So they have similar pattern with this, but the only difference with
Can you
with
write it, Dr. Henry? Because I cannot.
yes,
Yeah.
Okay, let me write it now. Sorry.
Yeah, but I don't think it's a common case. So
You know,
in
even a,
any
a case
stage, you
of,
can say Ehlers-Danlos, as you said,
yeah,
Ehlers-Danlos or pseudoxanthoma
if, even
elasticum.
in my neurology, Dr. Bazim, they brought an orthopedic patient in my neurology case.
Uh-huh.
Orthopedic, hemimelia, neurology. It was
What?
orthopedic case. Hemimelia, they brought for me. Hemimelia. In the feedback. Now they said in the feedback.
Okay.
Was by
Hemimania.
hemimelia, yeah. Hemimelia. Hemimelia.
Malia, what
An
is this? I
orthopedic.
don't know.
Now, I don't even know it. I don't even know what it is. But in the feedback, it says the patient has hemimelia.
Type both of
Hemimelia.
them, please. Write both
I
condition because I first time I hear about this. Anyway, maybe this is a extraordinary exam. It was UK center, right? Which
Yeah,
hospital?
UK,
This
yeah.
one, Doctor
It's
Henry.
what do you call it? Queen Elizabeth, Norfolk.
Is it known as a toxic center?
But it was my first, so most like all of us that wrote in the exam failed. Morning, afternoon, all of us that wrote in the exam, both in the morning section, afternoon section, or so that we all failed in all of us that did the
So
exam that day.
don't put it again as a
You know,
one of your exam center in the next diet. I mean, okay. Yes, I can see now. Hemimelia, first time to hear about it, and the other one, mimic, mimic
LOEYS.
Marfan syndrome.
LOEYS.
We can search about them and update the group. It's really difficult cases, and it's very rare condition to know about them. But at least we have to know Lois Deity syndrome (LDS). Okay, we will share it to the group. Then we can have update about both conditions. Anyone know about them, or we can read about them and update on the group. Okay. For the sake of time, I'll ask anyone has comment or question before ending the session.
I would like to add something.
Yes,
To be
Dr.
honest, this is the first time to hear about these conditions.
Exactly.
Even I haven't heard about that.
Yeah.
Okay, so we'll just have a look. Well done, Dr. Ayam. Just the same comment that has been given to you. It's just like I can see that you haven't reached the case from the early beginning. That's why you spend more time in taking history. But I think it's just it would be just specific to this case. So just take care of the time. The second thing, just in the history, I've just noticed that most of the doctors like forget the allergy question. I'm not sure if you ask about it or not, but this is my notice. So allergy is very important. In the examination, I don't know if you examined the eye or no, but I haven't heard that. But this is important examination since the patient has vision problem and symptoms, and also as a manifestation of Marfan. Also volunteer just to examine the back, just volunteering. I'm not sure if you volunteer about this or no. Eliminating some jargons. So if you can just take care of this also. If ask about genital ulcer, nasal stuffness. So some jargons, just be aware about that. Also, if you can just add to the investigation MRI of the back, just for the sake of completion.
Can I mean genital ulcer? I should ask about state like this private area ulcer. You
Yes,
mean right?
exactly. Yes.
Yeah,
Mm-hmm.
also in the private
Okay.
area.
Yes.
And nasal stuffness, just like any stuffness in your nose, because she also haven't like understand that.
Mm-hmm.
I think that's all. Yeah, but well done.
Okay,
Thank
thank you, Dr. Ahad. We
Thank
can
you.
read quickly the comment from Dr. Hemimelia is a birth defect consisting of unilateral or bilateral under development of distal part of the lower or upper limb. Fibular hemimelia consists of shortening of entire absence of fibula, previously known as fibular hemimelia, the most common congenital long bone deficiency. The Loeys Diet syndrome, LDS, is an autosomal dominant genetic connective tissue disorder. It has features similar to Marfan syndrome and Ehlers-Danlos syndrome. That's it. So it's nothing more than this in it. Okay, anyway, thank you, doctor, for sharing this information. By the way, I am updating the discussion and the photos related to every session in the Facebook group. So anyone miss the session or miss the readings or the chat or the figures or the photos, it will be shared on the Facebook post. So I am posting the same session as the title. Then in the comment down, you will find the picture or you will find the discussion or the differential. I'm trying to do more interaction in this Facebook group because I cannot post these things in the YouTube channel. Anyone missing the session, he can find this chat box in the YouTube group, okay? Sorry, in the Facebook group. Thank you, everyone. Thank you, Dr. Aya and Dr. Henry. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.